Hydrocephalus. This tutorial will describe the background of hydrocephalus, along with its causes, how it presents, how we diagnose, and how we manage it. The word hydrocephalus stems from the Greek hydro, meaning water, and kephale, meaning head, and it can be broadly defined as a disturbance of cerebrospinal fluid formation, flow, or absorption, leading to an increase in volume occupied by this fluid, with enlargement of the skull and atrophy of the brain. Hydrocephalus can be congenital or acquired, though is usually diagnosed in the neonatal period. Evidence suggests the prevalence of congenital hydrocephalus has declined to 0.82 per 1,000 live births in the developed world due to improvements in antenatal care. The incidence of acquired hydrocephalus is unknown, but about 100,000 patients a year have shunts inserted in the developed world. Hydrocephalus occurs following disturbances in the flow of cerebrospinal fluid. In a normal ventricular system, CSF flows from the lateral ventricles through the foramen of Monro to the third ventricle, where it flows down the cerebral aqueduct into the fourth ventricle and then on into the central canal of the spinal cord. CSF is largely produced by the choroid plexus, highlighted here in dark blue. The brain produces about 500 millilitres of CSF per day. This fluid is constantly being reabsorbed so that only 100 to 160 millilitres of CSF is present at any one time. Anything that causes a disturbance to the production, flow, or reabsorption of CSF can result in hydrocephalus. There are four main types of hydrocephalus, the first two being communicating and non-communicating. Non-communicating hydrocephalus is caused by an obstruction to the flow of CSF, whereas communicating hydrocephalus is caused by either overproduction or reduced reabsorption of CSF. Non-communicating hydrocephalus can be caused by anything that obstructs the flow of CSF and can be congenital or acquired. Congenital causes include aqueduct stenosis, which can also be caused by Bickers-Adams syndrome, Arnold-Chiari malformations, agenesis of the foramina, such as that of Monro and Luschka, vein of Galen aneurysm, and congenital toxoplasmosis. Acquired causes include tentorial herniation, as well as space-occupying lesions such as intraventricular hematoma and tumours. In contrast, communicating hydrocephalus is caused by either reduced CSF absorption or excessive production. CSF is reabsorbed by the arachnoid granulations, and this can be affected by meningeal thickening, infection, subarachnoid hemorrhage, neoplastic meningitis, or increased CSF viscosity. Similarly, anything that affects the choroid plexus can affect the production of CSF, such as a choroid plexus papilloma. The third type of hydrocephalus is called hydrocephalus ex vacuo, and this is where the CSF pressure is normal. It occurs following acquired brain injury such as stroke or traumatic injury, as the ventricles enlarge to compensate for the loss of brain tissue. The fourth and final type of hydrocephalus is called normal pressure hydrocephalus, and this tends to affect older people with an average age of 70 to 75 and is often characterised as a form of dementia. The ventricles enlarge, but the CSF pressure remains normal. It can develop after brain injury, but in most cases the cause is unknown. Symptoms progressively worsen over weeks, but improvement is noted immediately following removal of CSF. The clinical presentation of hydrocephalus varies depending upon the type, so I've split it down into acquired, congenital, and normal pressure hydrocephalus. Acquired hydrocephalus can present in childhood or adulthood and tends to present with classic symptoms of increased intracranial pressure, such as headaches, blurred vision, nausea and vomiting, drowsiness, and confusion, as well as other symptoms, decreased Glasgow Coma score, and even death. Congenital hydrocephalus tends to present very uniquely. You can see opening of the cranial sutures, a rapid increase in head circumference, dilated scalp veins, tense fontanelles, an increase in limb tone, as well as certain signs to look out for, such as the setting sun sign, which is where both ocular globes are deviated downwards, the upper lids are retracted, and the white sclerae is visible above the iris. There's also McEwen's sign, which is a cracked pot sound on percussion of the head. Normal pressure hydrocephalus is seen in the elderly and tends to present differently again. The symptoms can appear slowly over months or years. It presents with gradual memory loss, balance disorder, urinary frequency and urgency, urinary incontinence, and general slowing of activity. In order to diagnose and treat hydrocephalus, it must first be differentiated from other causes, and in infants, this most commonly means other causes of macrocephaly. Causes of macrocephaly that stem from the skull include familial causes, achondroplasia, rickets, and cretinism. Intracranial causes include hydrocephalus, hydranencephaly, which is where the cerebral hemispheres are absent and replaced by CSF, subdural hematoma or effusion, or space-occupying lesions. In order to differentiate hydrocephalus from these other causes, we can start by using clinical examination. In hydrocephalus, this should show progressive enlargement of the head when using serial head circumference measurements. We can then use a plain X-ray of the skull, which before suture closure should show widely separated sutures, and after suture closure may show signs of raised intracranial pressure, such as a wide sella turcica. If the fontanelles are still open, we can use cranial ultrasound to show ventricular dilation. CT or MRI can be used to show hydrocephalus and sometimes identify the cause in congenital, acquired, and normal pressure hydrocephalus. Once a diagnosis of hydrocephalus has been reached, the goals of treatment are to relieve the hydrocephaly itself, treat any complications, and manage any psychomotor problems that may arise. Treatment of hydrocephalus is most commonly surgical. The first step of hydrocephalus management is to remove any obstruction, whether that be a neoplasm, cyst, or hematoma. If the obstruction cannot be removed or there is no obstruction, the flow of CSF can be diverted using shunts, a third ventriculostomy, or multiple lumbar punctures. The two most common types of shunt used in hydrocephalus are the ventricular peritoneal, or VP shunt, and ventricular atrial, or VA shunt. The VP shunt diverts CSF from the ventricles to the peritoneal cavity. It's most commonly used in neonates and infants as it allows for excess tubing for growth. The VA shunt diverts CSF from the ventricles to the right atrium. It tends to be used in older children who are beyond the maximum phase of growth or those with abdominal pathology. It is important to note that the VA shunt is contraindicated in cardiopulmonary disease. Ventricular pleural shunts are a less common alternative. Unfortunately, shunts are not without their risks and complications. The most common complication is infection, and the greatest risk is between 1 and 2 months post-operation. The infection is most commonly caused by staph or strep. Shunts can also malfunction due to mechanical reasons, for example due to obstruction or kinking or plugging of the tube, or migration of the tube. Because of this, patients should be monitored for signs of increased intracranial pressure, fever, or abdominal pain after the procedure. An alternative to shunting is an endoscopic third ventriculostomy. This is where a neuroendoscope is used to visualize the floor of the third ventricle, where a tiny hole is made to allow CSF to bypass an obstruction such as aqueductal stenosis. As it does not leave a foreign body in the brain, it has a reduced risk of infection and failure when compared to shunting. The main risk is that of hemorrhage. In summary, there are many different types of hydrocephalus, and it can be congenital or acquired. The clinical presentation varies depending upon the type. In order to differentiate hydrocephalus from other diseases, we can use clinical examination, CT, and MRI. Surgery is the mainstay treatment for hydrocephalus, and we use different types of shunts as well as endoscopic third ventriculostomy. Thank you very much. I hope this tutorial has been useful.